So my name is Dr. Slua Yunan. I'm a senior lecturer in mental health, and today I'll be talking to you about anxiety disorders. So today we have two learning objectives in today's lecture. Firstly, we're going to talk about the clinical and associated epidemiological features of anxiety disorders as they're listed here. And then we're going to talk about the general principles that guide our management of anxiety disorders. But first, let's talk about some of the core concepts that kind of facilitate our understanding of anxiety. So, what do we know about fear and anxiety? Now, we use those two terms interchangeably in everyday conversation, but they are a little bit different. Fear is the emotional response to a real or perceived imminent threat, whereas anxiety is the anticipation of a future threat. So the difference we're talking about is time course. Now we know that having anxious feelings is a very normal and indeed an important part of human life. And that's because having moderate levels of anxiety can help improve our performance. And sometimes even high levels of anxiety can be appropriate when they're consistent with the demands of a situation, as is the case here. Now, I'm sure that by this stage you probably have heard of the concept of the fight or flight response. And this is a very important concept in helping us understand anxiety disorders. Now, the fight or flight response is triggered when a situation is identified as a threat. This allows us to become aroused, which then allows us to facilitate action, provided that action is possible. But when action is not possible, then the physiological arousal that would have helped gear us into action is then experienced in a series of symptoms. And so what we're talking about here is with the fight or flight response, there's an increase in circulation, and this is experienced in the sensation of having heart palpitations. There's a shift of blood from guts to muscles, which then we will feel in terms of having a dry mouth or feeling nauseous. Our respiratory drive goes into overdrive, and this then makes us feel like there's difficulty breathing or we're feeling like we're choking. There is an increase in muscle tension, and then we feel this through trembling or shaking or muscle pain. And there's a narrowing of attention, and this sometimes is reported as having difficulty concentrating on other things. Now, because anxious feelings are part of the normal human conditioning, sometimes the seriousness of anxiety disorders can be underestimated. Depression, on the other hand, is rarely undervalued or underestimated because it's often quite dangerous and is never really useful. Now, in 1908, Yerkes and Dobson first described a relationship between anxiety and performance that we can use today to help our patients understand the facilitating and debilitating effects of anxiety. In their paper, they reported that the performance on skill tasks improves as one becomes aroused, and thus initially anxiety can be quite facilitating. However, this performance then tapers off once the person reaches the peak, and at this point they're quite tense and alert. And then any increase beyond this optimal level becomes debilitating, resulting in a rapid decrease in performance and cognition. To make the determination that someone has an anxiety disorder, there are a number of factors that can influence our judgment. We need to look at the subject's internal state, we need to obviously make a clinical assessment, and we are guided by reports from family or friends. As clinicians, we will ask questions such as, tell me about your anxiety symptoms, tell me what your fear is going to happen. Obviously, we need to know the period of time that they've been feeling anxious, so how long they've been anxious, and then most importantly, is it impacting on their life and activities? Now, people with anxiety disorders not only will have specific and recurring fears, but that it's also important to remember that often these are fears that impact and affect their functional ability. Over the last number of years, there's been an increased understanding of the etiology of anxiety disorders. Now, broadly speaking, the likelihood of developing an anxiety disorder depends on a combination of life experiences, psychological traits, and/or genetic factors. But as you're going to see as I go through the anxiety disorders, they are quite heterogeneous, and so the role of each of these factors is likely to differ between the disorders and also amongst individuals. There are some anxiety disorders, such as panic disorder, that appear to have a more stronger genetic basis than others, whereas there are some other anxiety disorders that may be more rooted in stressful life events, such as specific phobias. Another interesting factor is that women tend to outnumber men in most anxiety disorders by about 2 to 1. And while it's not clear why females have high rates of most anxiety disorders, it's been postulated to be related to the fact that women experience a greater fluctuation of reproductive hormones throughout their life. But additionally, psychosocial research has indicated that women will often report a wider range of stressful life events, including those that have happened to others, as impacting on their life, whereas men tend to react to a more limited range of events and tend to only report those that are affecting themselves or close family members as ones that they have greatest concern about. So pictured here is a model of Gavin Andrews' book, The Treatment of Anxiety Disorders, which is useful to help patients understand why they've developed a particular disorder or particular symptoms at this moment in time. So I'll take you through each of the aspects of the model. The first aspect of the model is known as the event. We know from research that people will become anxious when they're threatened with a potential loss. And this loss can be things like a loss of love or position or wealth or safety. Life event research indicates that there is a strong relationship between negative life events and state anxiety, which is basically the current levels of anxiety. But this research has also indicated that this relationship is time limited and that most people over time will recover quickly, indicating that most people are quite good with coping with normal adversity. Another important point to remember is that often negative life events will appear quite threatening in the first instance, but then over time become benign. And so it's the appraisal of the event, which is our next element in the model, that determines our next steps. Often when we're faced with a negative life event, we ask ourselves questions like, is this a threat to myself or me? And this is because we're trying to understand how predictable and how much control we have over the event. Things that we've had prior experience with or that we know something about will be perceived as differently from things that are quite ambiguous or unknown. Arousal and symptoms are the next parts of the model. So here we go back to the fight and flight response. This is the physiological arousal that prepares us for action if action is possible. And as I said before, when action is not possible, then this arousal then becomes experienced as a series of symptoms. So the heart palpitations, the trembling, the sweating, etc. What you'll often notice in clinical practice is that people will fail to associate these symptoms with the immediate event that happened just before them, and instead they start to identify these symptoms as evidence that some terrible catastrophe is about to happen. So they think, for example, they're having heart palpitations, therefore they must be having a heart attack, etc. Now, neuroticism, or trait anxiety, is the other element of the model. We know that there are some people who year after year are more sensitive, more emotional, and more prone to experience anxiety than their peers, even when they're faced with the same situation. Neuroticism is considered to be a fundamental personality trait, and it's an enduring tendency to experience greater negative emotional states such as anxiety, anger, depressed mood. People who have high levels of neuroticism are ones that will cope more poorly to environmental stress and are more likely to interpret ordinary situations as threatening. The final part of the model is coping and the ways in which it can have either a positive or negative impact on our symptoms. So here we're talking about things such as mature defense mechanisms, for example, anticipation or humor, and this helps us deal with negative events or stressful situations. Later, when we talk about psychotherapies, we're going to, and during a mental health journey, you're going to start to come to realize that in most psychotherapy treatments, there is a great deal of effort targeted towards helping identify the patient's current inappropriate coping mechanisms and helping them replace them with better strategies. Okay, so we move on to the specific anxiety disorders. So the first one we will come across when you're looking at the anxiety disorders chapter in the DSM-5 is separation anxiety disorder. An essential feature of this disorder is that the person or child needs to display excessive fear or anxiety concerning the separation from an attachment figure or from their home. Now, this excessive fear and anxiety needs to exceed what would be expected given the person's developmental age. And then they need to require to meet the 3 out of the 8 symptoms listed below. So, for example, excessive distress when anticipating that they're going to be separated from home or attachment figures, excessive worry about losing a major attachment figure or possible harm coming to them, such as an illness or an injury. They have an excessive fear about some untoward event occurring, such as getting lost or being kidnapped, that then causes them to be separated from their major attachment figure. They often will demonstrate persistent reluctance or refusal to go out, to be away from home, to go to school or to work because of this fear of separation. There is an excessive fear or reluctance to be alone or without attachment figures at the home or other settings. There's also a persistent fear to sleep away from their home or to sleep in another room aside from that without their major attachment figure. They will have repeated nightmares that involve a theme of separation, and they have repeated complaints of physical symptoms such as headaches or stomach aches or nausea when they are separated from the major attachment figures or when they anticipate that this is going to happen. The disturbance needs to last at least 4 weeks in children and adolescents, and if it's in adults, then it needs to have occurred at least for 6 months. And finally, it requires that it needs to cause clinically significant distress and impairment in social or occupational or academic functioning. And it cannot be better explained by another disorder. The associated clinical features that will support the diagnosis of separation anxiety disorder. Sometimes people will demonstrate social withdrawal, they're apathetic, they're sad, they have difficulty concentrating on work or play. Depending on their age, the children will report fears of animals or monsters or burglars or being in some terrible catastrophe such as a car accident. In children, it will lead often to school refusal, which of course will then lead to academic difficulties and social isolation. When they are extremely upset at the prospect of separation, children may show extreme aggression or anger towards the person who is forcing the separation. And occasionally in younger children with separation anxiety, they will report when alone, especially in the dark or in the evening, that they have unusual perceptual experiences. So they will say, for example, there was a monster under the bed that was trying to get them, or someone staring into their room from the window. Children with this disorder will often be described as demanding or intrusive, and as adults they will look or appear to be quite dependent and overprotective. The 6 to 12 months prevalence rate in children is about 4%, and in 12 months prevalence rate in adults is approximately 0.9 to just under 2% in adults. Clinical samples indicate that there is an equal gender distribution. However, if we go into community-based samples, in children at least, females tend to be overrepresented. In terms of the risk factors associated with this disorder, what we can think about is environmental or genetic, for example. Environmental, it's been noted that this disorder can often appear after stressful life events. So, for example, if there's been a loss of a relative or a pet or a family member. If the child's experienced a change in schools, there's been a parental divorce, they've had to move into a new neighbourhood. In younger adults, it can be as a result of other life stresses such as leaving the home, for example, attending university, entering into a romantic relationship, or becoming a parent. There's also research to indicate that in some of the kind of other factors that influence it is that the children who experience parental overprotection or intrusiveness will have an increased risk of separation anxiety disorder. Genetically, there appears to be a genetic loading, at least in a kind of community sample of 6-year-old twins, about 73% there was a 73% genetic loading, and there was certainly a higher rate of this disorder in girls. So moving on to the next disorder, this is selective mutism. The essential feature of this disorder is a consistent failure to speak in specific situations where there is an expectation to speak, despite the fact that the child can speak in other situations. Now, the disturbance interferes with their educational or occupational achievement and with social communication. It needs to have occurred at least for a month in duration, and it is not due to the fact that the child is uncomfortable or has no knowledge of the spoken language. So it's not just because the child has recently arrived into the country. And it cannot be better explained because of other communication disorders such as childhood onset fluency disorder, which is stuttering. And it doesn't occur during the course of other disorders such as autism spectrum disorder or schizophrenia or another psychotic disorder. Some of the associated features that will support the diagnosis is that the disturbance is often marked by high social anxiety, and that this lack of speech will interfere with social communication. However, it is not uncommon for children with this disorder to sometimes use non-spoken or non-verbal means to communicate, such as grunting or pointing or writing. And sometimes they will be engaging in social encounters where speech is not required. So you'll find these children sometimes on the playground playing handball. Because it is a relatively rare disorder, we have point prevalence data on this, and it's about 0.3% to 1%. It doesn't seem to vary based on sex or ethnicity, but it does seem to be something that's more likely to be seen in very young children, so before the 5 years of age, rather than in adults or adolescents. So the third anxiety disorder is specific phobia. And the diagnostic criteria is that the person needs to demonstrate significant fear and anxiety related to a specific situation or object, and that this situation or object will almost always cause immediate fear and anxiety, and the person will go to great lengths to avoid it, or if they need to endure it, then they will endure it with intense fear. The other thing is that the fear is out of proportion to the real danger that this situation or stimuli presents, and it needs to be typically going on for at least 6 months and causing a real impairment in the person's ability to function. And it's not due to other disorders. Now, specific phobia was formerly known as simple phobia in a couple of versions before the DSM-5. Most people who have a specific phobia will often, acknowledge that their fear is excessive or unreasonable, but they cannot prevent themselves from going to great lengths to avoid this fear stimulus or object. The important part of having this diagnosis is that when the fear or avoidance starts to significantly interfere with the person's ability to kind of go about their daily routines or to work or to socialize, then it becomes a true concern. The DSM notes a number of subtypes of specific phobia, so they're listed here. Now, the first one is animal type, and this is obviously when the fear is cued by an animal or insect. This is something that we typically see in having a childhood onset. The natural environmental type is where the fear is cued by objects in a natural environment. So we're talking about storms or height or water. And again, we tend to see that this is having a childhood onset. This is about the second most common type that we see in clinical practice. The blood injection injury type is where the fear is cued by seeing blood or injury or receiving an invasive medical procedure or injection. This is relatively high in kind of a hereditary loading and is often characterized by a strong vasovagal response that will result in a patient frequently fainting. The situational type is where it's a fear that's cued by specific situations, and the situations can be public transport, tunnels, bridges, elevators, driving in closed spaces. Now, this tends to have a bimodal age of onset, so there's a peak in childhood, but there's often another peak in kind of mid-20s, and this is by far the most common one we see in clinical practice. The last subtype is the other type, so this is everything else that falls underneath. So we have some really interesting ones, such as space phobia, where individuals have a fear of falling down if they stand away from walls or other means of physical support. It's also where we see things like children's fear of costume characters. In terms of prevalence rates, it is not terribly uncommon. So there's a 12-month prevalence rate of around about 4% to 8.8%, depending on the type that we're talking about. But it is uncommon for these kind of specific phobias to really cause significant impairment. And as I said earlier, we see specific phobias usually occurring in childhood or early adolescence. But there's some research to indicate that may typically kind of emerge earlier in women than for men. In terms of risk factors, temperament is thought to play a role. So children or adults with high negative affectivity or neuroticism are at a higher risk. Environmental factors such as being exposed to overprotectiveness by your parent or having a parental loss or separation, or possibly being a victim of childhood abuse such as physical or sexual abuse, may also elevate your risk for this particular phobia. There's also research to indicate that if there's been a negative or traumatic encounter with a feared object or situation, this will then precede the development of a specific phobia. In terms of genetics, there is research to indicate that there is a genetic loading, specifically in terms of some particular phobias. So individuals with a first-degree relative that has an animal subtype phobia are more likely to have that particular phobia than other types of specific phobias. There is also research to indicate that there is a cultural influence on the diagnosis of a specific phobia, with some non-Western nations demonstrating differing phobia content, age of onset, and gender ratios. So we're going to move on to the next anxiety disorder. This is social anxiety disorder. Now, typically, this is a disorder where there is a marked fear or anxiety about one or more situations in which the individual may be exposed to possible scrutiny by others. And this scrutiny often is in the form of having a conversation with another person or meeting unfamiliar people, or being observed to be eating or drinking or performing in front of a person or public. The individual fears that he or she will act in a way that will show anxiety symptoms, and then once they show these anxiety symptoms, that they will be negatively evaluated. There are other particular criteria. So the social situation will almost always show or demonstrate fear and anxiety, and often these individuals will go out of their way to avoid social situations or else they will endure them with intense fear and anxiety. Now, this fear and anxiety is often out of proportion to the actual threat that this social situation will pose, and it's out of the context of a social cultural environment. Typically, this avoidance is had to have been experienced for at least 6 months or more, and it will lead to quite significant distress and impairment in their social functioning or even occupational functioning. It is not due to the physiological effects of substances or another medical condition, and it cannot be better explained by other disorders. So in other words, social anxiety disorder is really characterized by this fear and avoidance of social or performance situations. Patients will often have a very serious fear of being scrutinized, of doing or saying something that would be embarrassing, and of being seen to be anxious. So what's central to this disorder is this underlying fear of negative evaluation. But what makes it move away from general shyness to a disorder is that they have a really exaggerated anticipated consequence of negative evaluation. Often patients with social phobia will be demonstrating this disorder for a very long time, so it's quite chronic and debilitating, and it results in great personal distress and the failure to achieve a full social and occupational potential. As you can imagine, having this disorder can be linked to having other disorders, such as most commonly depression. And in terms of the symptoms that they're most concerned about, it's the ones that are visible to others that causes the greatest fear or concern. So they very much over-exaggerate how much they're sweating or trembling or blushing. And the reason is because they worry that if others can view them as being overly anxious, then they will be evaluated negatively. Social anxiety disorder was recognized as a diagnostic entity in the 1980 DSM-3 version. Previously, it had been thought of as an aspect of personality. Typically, we see this disorder emerge in kind of mid-teens, often out of a kind of childhood history of extreme shyness. It can be quite abrupt following a stressful life event, or can be more insidious. As I said, duration can be frequently lifelong, although its severity can fluctuate up and down depending on the stresses of the person experiencing and the demands of their life. So for example, a person who may have a fear of socializing or fear of dating, once they marry, this kind of starts to settle, but if they go through a divorce or the death of a partner, then obviously this will start to emerge again. So moving on to panic disorder. Now, the first part of the diagnostic criteria basically kind of outlines what you need to have in terms of meeting the criteria for a panic attack. So what this specifies is that you need to have 4 or more of the following symptoms, and that they need to reach a peak within minutes. So you need to have palpitations or accelerated heart rate, sweating, trembling, shaking, shortness of breath, feeling like you're choking, having chest pain or discomfort, nausea, dizziness, chills, tingling sensations, derealization, depersonalization, fear of losing control or going crazy, and a fear of dying. It is not enough to have one panic attack to meet the criteria for a panic disorder, but rather you need to have several, and in addition, the patient needs to demonstrate an ongoing concern or worry about having additional attacks and what this means to them. So is this an example, or is this a true meaning of that they're losing control or going crazy? And that then leads to a significant change in their kind of normal behavior. It becomes very maladaptive. So, for example, they avoid exercise because they may have had a panic attack while exercise, or they avoid wearing a particular outfit because they've had a panic attack when they've worn that outfit. Now, because of the nature of panic attacks and the very physical nature of them, we need to rule out general medical conditions through investigations. In terms of risk factors, individuals who score very high levels of neuroticism or anxiety sensitivity, which is basically defined as the belief that symptoms of anxiety are harmful, will be at increased risk of this disorder. Also, there is research to indicate that victims of physical or sexual abuse are more likely to have anxiety disorders, panic disorders, and interestingly, smoking is a risk factor. Genetically, as I said, there is a genetic loading for this particular disorder, although the exact details of the specific genes and their function remain elusive to researchers. Prevalence rate typically is about 2 to 3% in 12 months prevalence rate. We see a median onset between 20 to 24 years old, and females will outnumber males for this particular disorder. The next disorder I'd like to talk about is agoraphobia. The essential feature of agoraphobia is that there is a marked or intense fear or anxiety that is triggered by a real or anticipated exposure to a wide range of situations. Now, these situations need to be two or more of the following: using public transport, being in open spaces such as parking lots or bridges, or being in enclosed places, or standing in a line, or being in a crowd, or being outside the home alone. People will have really terrible thoughts, so they start to think that something terrible is going to happen, or they think that escape from situations might be difficult. Now, panic-like symptoms refers to any of those 13 symptoms that I just briefly talked about in terms of a panic disorder. So dizziness, faintness, or fear of dying. And other embarrassing symptoms can include potentially vomiting, or in older adults, a fear of falling over, or in children, a sense of disorientation or getting lost. This fear and anxiety needs to be evoked every time the person comes into contact with this feared situation, and often the individuals will actively avoid these situations, so they will deliberately change their daily routines. They will choose jobs that allow them to work from home, or else they will endure this feared situation with immense amount of distress, and often they will require having a companion with them. In its most severe forms, agoraphobia can cause a person to become completely housebound, and so they are unable to leave their home, and they become dependent on others for services or assistance. Depressive symptoms, as well as the use of alcohol and abuse of alcohol and sedative medications, often go hand in hand as inappropriate self-medication strategies. In terms of 12 months prevalence rate, it's around about 1.7%. Agoraphobia can occur in childhood, but typically it peaks in adolescence and early adulthood, and it is more common in women than men. So moving on to the final kind of anxiety disorder per se, generalized anxiety disorder. Generalized anxiety disorder, or GAD as it's also known, is an excessive anxiety or fear about a number of activities or events. Now, the duration and frequency of this anxiety or worry is often out of proportion to the likelihood of or impact of this anticipated event. The individual will often describe difficulty controlling this worry or keeping worrisome thoughts out of their kind of mind, or interfering with their kind of tasks at hand. And adults with GAD will often worry about everyday routine life circumstances, such as, the responsibilities they have at work, or their health, or their finances, or misfortune coming towards their children, or even minor matters such as household duties, or even being late for appointments. But GAD is more than just the usual worry that we all engage in. It's really excessive, and it really impacts on the person's psychosocial functioning. These are individuals who can't put aside the worry when more pressing things come along. These worries become quite pervasive, pronounced, and distressing, and often they will start to lead to quite physical kind of changes, so that the person will demonstrate motor tension, feeling over-aroused, and over time become excessively tired, develop tension headaches, and insomnia can be likely. It is one of the most commonly seen disorders in primary care settings. It has a 12 months prevalence rate of around about 0.9% in adolescents, by 2.9% adults, And again, females will outnumber males in this particular disorder. Though often people with GAD will report that they've always felt anxious or nervous most of their lives, but typically they start to come to clinical attention at the age of 30 years. Again, in terms of risk factors, it's the usual suspects, so it's neuroticism, it's negative kind of affectivity, and in addition, there is some increased indication that it could also be related to temperament. There are no clear environmental factors, and genetically there is a loading. It's reported that 1/3 of individuals with GAD will have a first-degree relative with GAD. I'd like to end off by talking about two more anxiety disorders that are listed in the chapter, but etiologically they're quite different. And these are substance or medication-induced anxiety disorder and anxiety disorder due to another medical condition. So I'll briefly talk about each one. So substance or medication-induced anxiety disorder is one where there is evidence from the history, the examination, and or laboratory testing that the anxiety symptoms have occurred either during or within 1 month of substance intoxication use or withdrawal, or that the medication is etiologically related to the disturbance. In terms of the clinical pattern that the patients will demonstrate, here we're talking about symptoms such as panic attack or just generalized anxiety. And the substances that can be involved can include things like alcohol, amphetamines, caffeine, or sedatives. In terms of the anxiety disorder due to a general medical condition, here is the diagnostic criteria, but clinically the profile can again can look like having panic attacks or just anxiety, and the incidence rates can vary according to the physical condition, and some of the physical conditions include things like endocrine conditions or cardiovascular conditions or respiratory conditions. So I'd like to start talking about the management of anxiety disorders, and typically we can kind of consider the management of anxiety disorders under these 3 categories. So psychoeducation, psychological treatments, or pharmacological management. Psychoeducation is when we talk to the patient about the nature of anxiety, its purpose, and how it can be important, but also how it then becomes quite debilitating. Most individuals with anxiety disorders will also suffer what we call secondary or worry about worry. So this is where they start to think that anxiety is dangerous and that they're going to go crazy or they're losing it. And so they start to worry about the fact that they're worrying. And clearly this can exacerbate the anxiety. So hence it's a really good targeted teaching moment to teach the patient that worry about worry is not a terrible thing. Psychoeducation is important because it often is a lead into some of our treatment options, such as relaxation or cognitive behavioural therapy or exercise or yoga. Now here, in the last bullet point, this is a really good online resource that you can go to in terms of seeking some more information about the use of psychoeducation as a treatment modality. And also, this bullet point also gives quite good information about psychological treatments of anxiety disorders. So, psychological treatments have been shown to be at least as effective as medication for anxiety disorders, with CBT being the greatest, has the greatest evidence base for efficacy. The CBT for anxiety often will start, as I said before, with psychoeducation about anxiety, and then we train patients about relaxation techniques such as progressive muscular relaxation or guided imagery, and more increasingly nowadays we're also kind of turning to what's known as mindfulness-based meditation. Now there is also elements of exposure techniques, especially if there is a specific feed stimulus. So this involves exposing the patient to a feed stimulus in a greater fashion until the anxiety subsides. The diagnosis will indicate what the stimulus is that we need to expose the patient to, So for example, social situations and social anxiety disorders. Now, usually these exposure techniques are coupled with behavioural strategies to try and address avoidance behaviour, so trying to kind of address the fact that they're going out of their way to avoid something. And also it is accompanied with cognitive strategies such as challenging their maladaptive beliefs. So, for example, going back to social anxiety again, that my anxiety will be noticeable. Other aspects of CBT for anxiety include training them in problem solving, helping the patient adapt more adaptive coping mechanisms, and also developing their interpersonal skills and relapse prevention strategies. In addition to exposure practice, there is homework-based tasks and monitoring sheets that will help the patient report on their experiences between consultations, and this has been really useful in kind of solidifying the knowledge that they get between sessions. And as I said, go to the website that I had in the previous slide for online information about the treatment of anxiety disorders in terms of psychotherapies. Now, the two medications that we use in terms of treating anxiety disorders is first line SSRIs and SNRIs. However, not all are available on the PBS listing, and this is something you're going to see in the next slide in terms of the table. Benzodiazepines are also commonly used in panic disorders and GAD. However, as you may know, their chronic use is associated with significant potential problems, including tolerance, dependence, withdrawal, relapse, rebound, and interactions with other medications. There's also no real established long-term efficacy base in terms of using benzodiazepines for a long time, but certainly in the kind of short term, they do have some benefits. And they do have good tolerance, but it really needs to be restricted to the short term, only up to about 4 weeks, and at the lowest dose possible. So here is what I was referring to in terms of the PBS listing for SSRIs in their use in treating anxiety disorders. So I guess the question is, should we be treating people with medication or with psychological therapy or with both? Now, often you do see anxiety disorders having both CBT and medication as a commonly kind of treatment modality, but this has not necessarily been shown to be superior in the long term, despite the fact, as I said, it's quite common in clinical practice. Indeed, some researchers consider that the use of the concurrent use of some of the medications and treating a person with CBT can have detrimental effects to some of the kind of exposure-based therapies. So, specifically in terms of the extinction phase of exposure-based therapies, and that is because there is research to indicate that there needs to be good glucocortical activity in terms of learning emotional material. Now, patients often will value both CBT and pharmacotherapy, but over kind of the long term, it tends to be a preference for CBT than medication. And in actual fact, there is some research to indicate that CBT over the long term can be more effective. Now, a commonly used rule of thumb is to start with CBT, and if the patient does not respond, or if there are significantly high levels of depression present, to also consider pharmacotherapy. But in more severe forms of presentation, then starting off with an evidence-based medication may also be considered prudent before starting CBT. But as always, we really need to consider the patient's preferences and characteristics when making this clinical decision. So to summarise, I'd like to just kind of briefly go over the anxiety disorders that we've spoken about today. Separation anxiety disorder is a disorder that demonstrates, people will demonstrate fear and anxiety from being separated from attachment figures. Selective mutism is a failure to speak in situations where there would be an expectation to do so. Specific phobia is fear and anxiety around circumscribed objects or situations. Social anxiety disorder is fear and anxiety about or avoiding social interactions where there is the possibility of being scrutinized. Panic disorder, this is a recurrent and unexpected panic attacks and then accompanied by persistent concern or worry about having more panic attacks, which then results in maladaptive behavior. Agoraphobia, this is where there is fear and anxiety related to two or more situations, public transport, open spaces, etc., in which escape may not be possible or may be difficult and there may not be help available. And finally, generalized anxiety disorder. This is where you have a persistent and excessive worry about various domains that often will lead to physical sensations or symptoms such as headaches and fatigue. So, come to the end of the lecture. I am going to talk a little bit about some of these disorders later on when we talk about CBT for anxiety and depression. Thank you.